You're watching CTOM TV. Knowledge is power.
Candace is asking, I have small cell lung cancer, has done chemo, Tecentriq, which I haven't heard of, but she says is a new immunotherapy just released, and radiation. Okay, so chemo, this new immunotherapy, and radiation for small cell lung cancer. The tumor came back in the summer, and she's now on a chemo break. Was told I'm stage 3B, inoperable and terminal. Do you have any suggestions?
So what type is it? Small cell, did you say?
Small cell lung cancer.
So small cell is interesting. It's typically a more aggressive, harder to treat cancer. However, over the years, we've started to see in certain cases of small cell cancers, some of the genetic features that are the treatment options for targeted therapies. So in fact, we've had a patient with an EGFR mutation. We had a patient with an ALK mutation. We even had a patient with a BRAF mutation.
Somebody with the small cell.
With small cell.
Okay.
And there's some novel chemotherapy combinations. Temozolomide, which is used for GBM, seems to be effective. What's important with small cell is you have to look at the co-features. You know, is there any other features to that disease? You must get tumor DNA sequencing for small cell. You must. At least then it will show you if there are treatment opportunities.
There's just too many variants.
Too many variants to look at. And then you also want to look at the types of cells that are found within the tumor. And that's going to give you a good indication of what's going on there. Or found within the biopsy.
Right. So
like mucinous, for example.
So it's not too late. We don't know.
It's hard to say.
Right.
It's really hard to say. I mean, you have to look at the mutations and really determine that. So tumor DNA sequencing is always going to be the first step.
Right. Yeah. Again, back to basics. We got to find out what's caused the cancer.
Enough guesswork.
And what the options are. That's right.
Guesswork.
Yeah, that's right. But typically it doesn't take that long, just in case you're wondering. It's about 3 weeks to have all the testing done, another week maximum for your own personalized treatment plan, and then to coordinate with your oncologist or to connect you with an oncologist who will prescribe the right targeted therapy for you. So 3 weeks to a month maximum.
And the drug she mentioned is a newer PD-1 inhibitor. It's actually a PD ligand inhibitor, tezolizumab is his brand name or his functional name.
Okay.
So we don't have a lot of data on that drug. It's relatively new. I'm not sure I would go with that one right off the bat.
She's already had it.
Okay. Yeah. So it's probably a clinical trial.
Okay. Right. But again, a lot of oncologists are experimenting understandably or prescribing these new immunotherapies, but if you don't have their genetic testing
or the knowledge of the drug,
or the
difference between a receptor ligand inhibitor or ligand inhibitor, there's so much information you need to look at. The drugs are very different.
Yes, so don't give up hope,
No,
Candace.
Don't give up hope.
But time is wasting, so we want to get those diagnostics as quickly as possible, for sure.
Thank you for watching CTOM TV. Subscribe below and stay informed.